Okay, Bob, please introduce yourself and give us some background on your years of experience as a PT and ATC.
My name is Bob Mangine. I'm the Associate Athletic Director, Head Football Trainer at the University of Cincinnati. I am a physical therapist for 39 years, and I'm an athletic trainer for 43 years. I've been here at the University of Cincinnati managing the football program for the last 14 years.
You knew the patient in this case study before the injury and participated in all phases of his rehabilitation. Can you share with us what baselines you had on this athlete and how these guided the rehab program?
The patient was a highly recruited athlete coming out of high school. He, as a true freshman, really had a great camp. We had all the baselines we typically have on our freshman players, from visual baselines to strength baselines to mechanical baselines. The patient was a high-end athlete, wide receiver, who was very, very good at what he did in terms of football. He was an exception. He was a little bit higher than most freshmen coming in, to the point that he may have played his freshman year in Division I college football. So that tells you what a pretty good athlete he was.
Can you describe the general rehab plan and elaborate on the visual program outlined in this paper?
The general rehab was I don't want to use the word typical post-traumatic brain injury rehab. It was an integrated approach based on multiple specialists in their areas to try to give him his best chance at returning to normal life. Basically, we worked your typical neurological type of rehabilitation processes, from normal developmental technique to skill technique to reacquiring his muscular strength. And with the level of injury that he had, it was pretty significant, so therefore his processing was very slow and limited. We really worked hard on getting his cognitive visual skill level back, because he was a highly skilled athlete, and his visual skills, as we determined in camp prior to the accident, showed that he had very high level visual acuity abilities. So, as part of the overall integrated approach, especially working on synergistic patterns, working on normal developmental techniques, getting the visual field back into play to help him with his balance, coordination, kinesthetic awareness was really critical. So we sat down probably every 2 to 3 days, each of the practitioners that were dealing with his rehab, and making sure that we were highlighting specific areas, knowing what his skill set was prior to the injury.
In your experience, what has his expected outcome has compared to his eventual outcome been? What are the typical difficulties you expect in a TBI patient, and how did you manage these?
Well, this was not your typical mild traumatic brain injury. This was not mild in any sense of the word. This was a significant brain trauma, which led to surgical intervention. So I think that when you look at what the expectation is for return, your first major expectation milestone has to be ADLs, normal activities of daily living. You got to make sure that you can try to get the individual back to where he can assume his academic level, hopefully give himself the best opportunity for a career pathway, making sure that he had good enough cognitive skill senses to be able to hold a job after graduation. Those kind of things we were looking at. We weren't looking at football. We were looking at our normal ADL activities for an individual to be successful in life, to be successful in occupation, to be successful in relationships. I think that to expect too much more than that would have been, would it be possible? Anything is possible. Would it be probable? No. We were more worried about him as an individual and making sure that he could do daily individual activities.
How important was the visual and neurovisual rehab in his recovery?
Well, as we discovered, and of course we wrote about in this paper, the visual element in our minds is very critical, I think. Basically There have been some recent papers, especially in peripheral joint injury, in which neuroplastic adaptation can occur. And I think neuroplastic adaptation in neurogenic injury certainly is a possibility. And they're finding, and just as we are finding, that the visual input is critical. And luckily, as a PT, I did go through a one-year training program in neurological injuries. I worked with many strokes patients that allowed me to have the insight to where we used visual training way back in the 1970s in order to give kinesthetic and proprioceptive feedback to the brain to what the extremities are supposed to do. So if you can see it, you can move it, so to speak. And we feel that with our MTBIs, as well as even our other, to me, any brain injured individual, the visual component to sense and to provide the kinesthetic awareness back to where the peripheral joint should work is really critical.
How did you interweave the neurovisual treatments with the PT-OT rehab?
Again, it's when we look at visual training, it's one part of the total picture. So we have to look at pattern training, synergistic training, and actually we're working more and more with neurovisual training with pattern work so that they can get a better sensing of where they are with their kinesthetic capability. So I think that the visual training is a key element, because if you can work on, and again, not just on the Dynavision board or not just with Brock String, but with the ability to integrate other visual field movement type of exercise programs. So you have your traditional PT where we really highlight PNF, synergistic patterns, normal developmental technique. When you have a brain injury, it's like taking a step back to infancy, because you have to reprogram the brain through your typical normal development pattern skill activity. But the visual component, to give that visual component while they're doing that, I think assists in expediting and actually potentially being a little more efficient in your rehab process.
Is the work you did in this case transferable to other cases of similar severity? Any advice for PTs or other therapists who are considering doing post-TBI vision neurovisual therapy?
It's really, since we've gotten down this track, we always knew that vision was critical or a piece of the puzzle. But I think that since we played with this over the last 7-8 years now, we're seeing where the visual field command, I call it, kind of how I control my visual field, how I move through my visual field. In order for me to prevent injuries, it's my ability to take an athlete from point A to point B, have them find point B in a safe, efficient environment, so that when they encounter an outside environmental stimulus, they can come up with a strategy that takes on that environmental stimulus and be successful. Here's where vision training helps. You can adjust the feet, you can adjust the body position while you're giving them their visual stimulus. And again, it goes way beyond just the typical Dynavision patterns that we use, but it's also taking them and having them do the saccades and other things while they're in a motion state. Because again, I go back to, I'm a neurological PT that does orthopedic rehabilitation, because no group influenced me more than my stroke patients did when it comes to learning about proprioception, kinesthetics, the cognitive skill network in your brain, and how your visual input can help assist the efficiency in training that. So I think that, today, a lot of my talks, whether it's after ACL, after shoulder surgery, after brain injury, the visual component is now built in, because we know that no matter what the injury, could be a brain, could be an ACL, could be an open capsular shift, the neurological system's disrupted. And we're finding that the visual neuroplastic changes that we're getting in the rehab with our training, visual training, is really key.
Thank you.
You're welcome.